about that.
Yeah.
So today, Dr. Professor Ian Hickey, the co-director of Health and Policy at the University of Sydney's Brain and Mind Center, is speaking. He is a distinguished figure in clinical psychiatry, and he has a focus on common mood disorders like depression and bipolar disorder. And he has served as a senior principal research fellow for the National Health and Medical Research Council and as an inaugural commissioner on Australia's National Mental Health Commission. I myself had the pleasure of visiting Sydney's Brain and Mind Center as a visiting PhD candidate to work on the digital mental health project there, mental health team there in beautiful Sydney. And I had a wonderful experience. And today, Professor Ian Hickey is presenting Right Care First Time Where You Live, program for Australian youth. The floor is yours.
Thank you so much. And as I was just saying to Andy, I apologize slightly for talking to you from a car park in Edinburgh, Scotland, having been delayed getting to a hotel and a meeting here. But it's a great pleasure to talk to colleagues in Canada, particularly in BC, about what we're trying to do in Australia and the challenges we all face in trying to develop services for young people with mental health problems and substance misuse, and the challenges that we have of meeting those demands at scale and with quality services. So I'm just going to start to share my screen with you and just check with Andy then that you'll be able to see it. Oh, Andy, you've got to allow me to share my screen.
Absolutely. There you go. I think you should have the ability to do that now.
Okay. And there we go. So I think if you can see that highly personalized and measurement-made care, you can see that, Andy, just give me the thumbs up. Yeah, okay. So this is the challenge, I think, for us, is to how do we deliver really highly personalized and measurement-based care for a whole range of emerging mental disorders and related substance abuse. And so in Australia, we like to use the expression, right care, first time where you live. And in places like Australia and in Canada, I think that's the challenge for us. The opportunity when we have with young people, do we deliver care that will really work the first time we meet people, not assume they're going to come back, not assume that it'll be okay another time, and get that as close to where they live. We both live in countries where people are often distributed, may not be close to specialized services, may not be close to those services they most need. Just to say, I'm going to talk a little bit about technology, and we have a spin-off company associated with that. And as Andy said, I've been one of the National Mental Health Commissioners. So 3 things I really want to talk about. One is early intervention for youth at scale. Not can we just treat anybody? Can we attract the young people who really need care to that care? Can we help to make that work? In our approach to that, we talk about clinical staging, trying to get people at early stages of illness, not later stages of illness, and early stages before complexity sets in to actually lead those models. And using new service models, can we actually make a difference as we deliver those new service modules? How we do that, and particularly use of technology to assist in doing that, particularly important consideration, both for measurement-based care and getting there at scale, and the real challenges we face in using new technology models in those areas. And then lastly, how do we get into the regions that we're talking about and implement models of care and in a regional way, in ways that will actually result in more effective strategies in care? Just to really say, in all of our societies, it remains the case that the years of potential life lost due to suicide outstrips all other major illness groups. As the case in Australia, as in Canada, we really don't invest in those areas that we really should. Things like cancer, heart disease, infection dominate most healthcare thinking. But in truth, if our societies really cared, they'd be investing in suicide prevention and youth mental health and substance abuse problems. In Australia, we regularly measure the 12-month prevalence of mental disorders. And importantly, 1 in 5 people have mental disorders. Most importantly, of course, is to recognise the extent to which these disorders have their onset and their greatest burden in young people. And then what we see for the common disorders are those related to anxiety, depression, and substance misuse out there in the wider community. In our society, as in most society, less than half of those people ever receive effective care, and often not when they're young, often when they're only middle-aged or come into primary care systems or other family care systems at a later age. But they remain the dominant problems, and they've stayed pretty static. We've been recording these figures in Australia for over the last 20 years, and we haven't actually reduced the prevalence at all of those conditions. In fact, in recent times, the amount of mental distress and then formal disorders have actually increased. So if you look at the most recent statistics that we have in the post-COVID era, you see the disorders affect young people, but the group that's had the largest increase has been in young people. So we've seen an increase in mental health and substance abuse pre-COVID. And then in the post-COVID era, contrary to people's expectations that things will simply go back to normal or as they were, they've significantly increased. And so while we've seen an increase in healthcare seeking for all age groups in the post-COVID eras, it is most marked, just to emphasize that again, for young people. And it's an interesting combination of mental distress, not all of it sort of formal disorder in the way that we understood pre-COVID, but going on and being associated with substance misuse. So we see those peak ages of onsets. And the challenge for us in all of these areas is how do we respond during those particular adolescent and early adult years to the range of mental disorders, including substance misuse. What's been really interesting in our kind of world is a kind of tension between what people want to see as prevention, early intervention, and later treatment. It's been important, I think, to look at in our work, particularly about where the greatest opportunities are for affecting the population prevalence over time, and really to focus on that intersection between what previously has been called indicated prevention and early treatment or early intervention. So in the models that we have now for prevention and early intervention in the Australian setting, we really emphasize that part of the circle of so-called early intervention, or what others would call indicated prevention, working with people who have not yet necessarily reached a threshold for full disorder, but have symptoms, seek care, often have concurrent physical health problems or concurrent substance misuse problems in addition to their mental health difficulties, and not simply wait till they've developed full threshold mental disorders. A really important kind of concept, because all of our areas struggle, and certainly our specialist areas struggle to provide services to those early in the course of illness. And of course, there is this intrinsic paradox from public health, attributed largely to Jeffrey Rose, that you need to treat a whole lot more people earlier on, and not just those at the most severe end of the spectrum, if you want to really change the population prevalence. We've been looking at actually modeling of these kind of effects in our recent kind of work, particularly what would lead to the most population level effects. Because a lot of our work in these areas adopts stepped care models, adopts models that really say to people, wait till the disorder is most severe, wait till the disorder requires more specialized care before providing any effective intervention, because that's all we can afford, or that's all we can provide on an ongoing basis. When you actually look at trying to model that over time, what we really find is that the most impact would be had at this stage for indicated preventions that work. If we had universal preventions, if we could do something for the whole population that really worked, that would have a big effect too. But at this stage, we don't really have anything at the universal level that actually works to that degree. What we do have are treatments that work for particularly symptomatic groups. And so when you model this at the moment, the greatest way forward would be, in fact, to effectively institute indicated preventions or early intervention, while continuing to look at strategies that may benefit the whole population. We've also been looking at how you might stabilize the system so that actually you don't actually get just more and more expansion of services without necessarily getting effective services. And this is an important kind of concept as we spend more and more money in mental health and substance misuse. Do you just pour more and more money into the systems that we've already got, or do we need to look at the mix of services more effectively? And this is an important kind of issue of getting the mix of primary care and specialist services more effective in their distribution. So we have a model that we developed in Australia, which suggests at the moment we spend about $7 billion of federal money, about $10 billion in constant money on the whole system. We probably need to spend a lot more, but we could double the amount of spending we currently have to about over $20 billion and not necessarily achieve a better outcome. We've actually modeled, if you've got the right model of primary care services and specialist services together, you could probably spend about $14 or $15 billion, actually not as much money, but actually more effectively if you've got the right mix of services. And I say this particularly because a lot of our work in Australia and a lot of work I've been associated with has simply emphasized better access to services, more people simply getting through a front door of a headspace service, our primary care services for youth, or a family practitioner, or some other youth services, without necessarily providing the additional specialist services that would help them actually recover from the conditions that they actually have. Our models suggest you need to do both. You need to have smart pathways of entry, but those pathways need to deliver services that actually work as well. And that basically you need to look at the access plus the specialized services for treatments that work to get the best outcomes. Simply to say this is challenging in the face of increasing demand. We certainly saw during COVID increasing demand, more young people coming forward and more young people coming forward with more self-harm. And that self-harm being a complicated issue of symptoms, substance abuse, impaired functioning, and presentations for care. As I say, that's continued in the post-COVID era. Importantly, in Australia, back in the 2000s, work led by Pat McGorry and myself and other colleagues led to a new approach to primary care to say that simple family practices, general practices, a system we inherited from the British, and I'm in the UK at the moment, great National Health Service ideas of primary care developed in the 1950s, did not meet the needs of many young people. Many young people did not get effective care from those services. What we did, our Prime Minister at the time and our national system said we need a new system of primary care. And that led to the establishment of these new national headspace services, a new front door for young people to come into care through those systems. They've now reached over 150 of those being established around the coasts of Australia, being established around our services. And that's been happening now over the last 15 years. And in addition to that, through services like that developed by my partner, Liz Scott, and others, we've been developing other centres to try and provide degrees of specialist backup to those services. And that's a process of development. We haven't developed nearly as many specialist centres or specialist services to back up those primary care services that were established or have been established over the last 15 years. What we see in those services when they come through the door in our most specialised services is a good deal of anxiety and depression, but a range of other services as well. We've tried to develop a model of care to meet those particular needs. And that's where the terminology, right care, first time, comes from, highly personalised care. And it's got 7 kind of key elements that I want to discuss briefly. And this has been written up in the Medical Journal of Australia in 2019. On the left side of that particular circle that you can see, there are 4 elements related to highly personalised assessment. What we need to do during the assessment phase to improve access to care. And then what we need to do during the treatment phase, the measurement-based care situations, to necessarily improve the delivery of care over time. So I want to run through briefly those elements. The first is a multidimensional assessment, taking into account the needs of young people when they first present, not just the symptom count they have, but the range of needs that they necessarily have. Right at the top of those, we like to talk about their level of function. Are they in education? Are they in school? Are they in employment? Are they in training? The goal of what we do needs to be not just to reduce symptoms, but to make sure that people can function and move through care effectively. The other 4 dimensions that we emphasize are the illness types that they have, the symptom sets, whether they have mood disorder symptoms, anxiety symptoms, early psychotic symptoms, etc. That's just one issue of what kinds of mental health phenomena they have and what stage of illness they may be at. But the other 3 that are really important are those related to self-harm and risk, those related to alcohol and substance misuse, and those related to physical health comorbidities. What we're trying to do in multidimensional assessment is make clear what sets of needs a person has and then track those in a young person over time, not just to be focused on what level of symptoms they have. In work that Pat McGorry led in Australia back in the 1990s and elsewhere, what's often clear is the extent to which young people have impaired function, trouble going to school, trouble going to employment, trouble going to education, even at relatively low levels of symptoms in association with substance misuse, other physical health problems, and at times quite significant thoughts of self-harm or self-harming behaviours. So simple diagnostic thresholds that just focus on symptom sets often miss the point with young people as to what else they might require and what other needs they might have. Of course, that's very challenging for services because it says you might need to be doing more than just mental health. You might need to be attending to substance misuse, to physical health problems, and you need to be thinking about how you keep a young person in function, how you support them in school, in education, in training, or in employment to stay functional throughout this particular difficult period. And that's important to say because we've been looking very much at suicidal behaviour in those particular periods. And of course, these are groups that are significantly increased risk. So often they're said to be low symptom, but they're not often low symptom for risk over time. And the suicidal behaviour itself is preceded by low function, and suicidal behavior itself predicts not just suicidal behavior in the future, but the onset of other major disorders as well as further function. So suicidal behavior, which is often minimized in our services, and certainly minimized in our emergency partner services, should be a hallmark of attracting serious assessment, multidimensional assessment, and also serious consideration of longer term implication. Sadly, in our systems, it still remains the case that many young people with suicidal behavior receive only very brief or one-off interventions and are at strong risk of repeating the behavior or going on to very poor outcomes. We've also been tracking the nature of those developments of those symptom sets with function, with substance abuse over times, and the temporal dependencies between the social, emotional, and physical health factors over time. The point that I want to make is the same as our multidimensional point. It's the way that those things interact over time. And if one has only a very narrow focus on mental health and its symptoms, or a narrow focus on substance misuse, or a narrow function focused on just function, one can miss the point, or a narrow function just on self-harm. It's the interrelationship with those things over time that tend to drive younger people on to worse outcomes. The second point I want to make is one of tracking pathways of developmental illness over time, what we see as pathophysiological pathways. And this has got to do with really recognizing the complexity of development from early childhood phases through the adolescent phases, but the ways in which we would differentiate those that have common forms of anxiety and depression from those who are at risk of being on more significant pathways to bipolar disorder and pathways to neurodevelopmental disorders over time. One of the pathways I'd like to draw particular attention to is the early onset of substance misuse in association with those with very unstable moods, and the association between that particular group, unstable moods, mood instability, and substance abuse, of being a particularly increased risk of developing bipolar disorder, self-harming behavior, and poor functional outcomes. The third bit I really want to emphasize, the concept that we developed with Pat McGorry and others of clinical staging, wanting to pick people up in early stages of illness before they develop more classical, more severe illnesses over time. And staging is a very important kind of concept to us as a treatment point of view. Best to pick people up at early stages when they're in smaller, more shallow holes, and help them to recover quickly, and then to engage in secondary preventive strategies than waiting till people are in very deep holes that are harder to get out of and that are harder to achieve full recovery. Really difficult concept, because really, although early intervention and managing earlier problems is so much the normative situation in cancer, in heart disease, in other areas, it is still not the normal situation for many young people with mental health problems or substance misuse. In our work, it is to say these earlier stages are at high risk of progression to later stages, and it would be better off to try and achieve functional outcomes early and then put in place secondary prevention strategies. And those secondary prevention strategies, whether they're medical, psychological, behavioral, functional, combinations of which will be likely to prevent a young person becoming recurrent or falling into much deeper holes that are much harder to manage at a later stage of illness. So those staging models we emphasize try and pick people up before they develop full syndromes, whether those full syndromes are of depressive disorders, bipolar disorders, psychotic disorders, whatever. It tries to pick people up at an earlier stage where they have a significant impairment, they have significant symptoms, they may be before a full-blown episode of any particular disorder, but it's the optimal opportunity for providing effective care to prevent progression to more severe mental disorders as well as worse functional outcomes. In terms of looking at what those sort of things that predict those bad outcomes, in addition to the ones I've mentioned, there are important aspects of cognitive function that are often poorly assessed as well as to what's contributing to those poor functional outcomes. And those who have significant cognitive impairment prior to the development of mental health problems or an association with mental health problems tend to do worse over time. In addition to the emphasis on cognitive impairment and function, we have a lot of emphasis in our work on physical health and the opportunity for early intervention for physical health problems, often ignored in young people with mental health and substance abuse. And very much in work led by my partner, Liz Scott, in this area, we pick up early insulin resistance, early evidence of metabolic disorders before young people have become overweight, before they've developed major complications of the treatment, an issue often ignored in the physical health of young people when they come forward. If you look at what predicts progression in many of these disorders, there's a range of factors we can look at. First, to say, if you pick up people at these subthreshold syndromes, they are at increased risk of progression to major disorders. And in terms of the key predictors of that, you see things like psychotic experience and circadian disturbance, sleep-wake cycle disturbance, along with the presence of earlier childhood disorders as being key factors. I just want to emphasize that when we talk about who goes forward, in a lot of the work that's done in early psychosis or early mood disorders, people only tend to emphasize if the person has psychotic symptoms or they have major mood disorder symptoms or hypomanic type symptoms of bipolar disorder. The truth is that most of the people who come forward have very non-specific syndromes of anxiety and depression, and they account for the great majority of people who actually progress to later stages. So simply trying to focus on those who have psychotic symptoms or have hypomanic symptoms, you're going to miss most of the people who do go forward. It's more complicated than that over time. When we've been looking, for example, at people go forward to bipolar disorder and psychotic disorders, you see a whole range of factors, but I just want to emphasize two here, or three actually, that are important. For all of these disorders, people who've had prior suicide attempts, independent of any other symptoms, are at risk of going forward. Those who've had prior childhood disorders, particularly childhood depression, are at risk of going forward, and those who have poor function. So many of the things that we don't talk about, not symptom factors, but other factors that predict going forward to worst outcomes. Worse function when they present. So being more likely to be out of school or out of employment or out of training, prior suicide attempts, and prior childhood histories. The sort of things we need to take account of alongside symptom sets. So they're the sort of things we talk about in terms of assessment. When we talk about outcomes, what we try to track people for, then we also need to take this multidimensional approach. And I want to say in terms of tracking outcomes, this is important. A rather unusual thing that I often say as a clinician is I'm not so concerned about those people who get better. I'm concerned about those people who do not get better or get worse, who deteriorate, and detecting that early. And that's really what measurement-based care is about, tracking these sets of dimensions that I was mentioning earlier on and seeing not who's improving, but who is not improving and who is deteriorating, who is getting worse over time that we need to attend to make sure that we review what is happening in those cases and look to provide better attention to that care. What is it about this individual, this young person that's not improving? Do they need better access to specialized care? Do they need access to multidisciplinary care to improve that situation? Now, we've been looking at that in these own headspace types of sets in very important work that we're looking at. And then sadly, where we've not provided very effective intervention, about 2/3 of those young people do not have good functional outcomes. That is, they're getting into care, but their function is not improving. It's staying the same or getting worse at a longer term. And this is a really challenging idea. In other words, access to care is not sufficient to deliver good functional outcomes. You've got to provide more than a front door. You've got to provide a real service, and that real service needs to focus not on just reducing symptoms, but on producing better outcomes. So when we look at the groups of what is actually happening here, you can see this diagram of on the right here, the four groups that we identify in terms of functional outcomes. Those who came in with good functioning tend to leave with good functioning. But a lot of those that came in with poor functioning continue to have poor functioning despite the fact that they've come to care. We think that reflects they've not received sufficient care or sufficient specialized care. Another group improves for a while, but then deteriorates again. And we suggest that's largely got to do with how brief many of our interventions are, that we need to sustain interventions over a longer period to achieve good functional outcomes. This is challenging because we put a lot of emphasis in Australia on getting people into care. What this is really saying is we need to get people into care, yes, but then we need to provide effective care, and effective care with an emphasis on function to achieve very good outcomes. And that predictive status, who does badly over time, is predicted by poor functional status at entry, prior childhood disorders, having a Moore syndrome, but importantly, substance misuse, concurrent physical illness, and suicidal behavior all also predict a poor functional outcome at up to 2 years after presentation for care. The next aspect I want to emphasize is using technology in these care pathways that we have. And we have a large services trial at the moment called Empowered, which is using digital technologies to track care and bring to the attention of services as quickly as possible the fact that a young person is not improving or they're deteriorating. This has been really interesting because using up-to-date digital technologies to feed information back to services challenges the services to respond in real time. Really hard for the services to do, to actually change what they do to respond to when a young person changes rather than just making an appointment sometime in the future. We'll see you in 2 weeks. We'll see you in 4 weeks. We'll see you in 3 months. No, we'll see you when you need to be seen when things are not improving. A really challenging set of services trials that we're involved in at the moment. I want to say something about just the variability of system. These health systems is to say we're not just doing individual things, that when we need to build systems, we need to reduce the variability. And just for the groups, this is about groups with a great deal of variability in their mood patterns. It's important to reduce that variability. We do a lot of things where we tend to ignore the extent to which a young person is moving around in terms of the variability of their symptoms over time. One of the factors we see in a lot of modeling is we need to produce more stable situations on a day-to-day basis. And if you think about that, that's not something our systems do very often. We think about what the next month will be or what will happen in the next 3 months, not what's going to happen on a day-to-day basis to produce a better outcome. I want to move on to what we're doing now at a regional level. That's what we've been doing at an individual level, trying to enhance services. We've also been working in specific regions in Australia, 8 sites across the country, to see whether in particular regions we can get better coordination of care between all of the service providers and between education, healthcare, and other social services in those particular areas. Get the right mix of services. Can we actually look at how a system functions over time? What are all the factors and what sets of factors would have the most impact on suicidal behavior, on presentations to hospital, presentation to emergency departments, and return to works, and use simulation models. Contrasting new interventions, as shown here in intervention pattern, with simply service growth. A lot of people think we should just do more. Fund more psychologists, fund more GPs, fund more specialist psychiatrists, fund more community services, so-called service capacity growth. What a lot of these models show is you can pour a lot more money into services and only get relatively small effects. What they really show is we need to do things really differently. And one of the biggest effects that we get is from what we call technology-enabled care, coordinating services by using modern technologies. I say this as I reach for my own phone, which I'm using at the moment to talk to you, to connect with you from the UK through to Canada, is to use technologies in a personalized way to track what is happening and to use systems that can run through technology so that a young person and their family can say what is happening. And as they move from provider to provider, what is happening over time, not just for a very short period, but over a longer period to see what has happened. You get the most impact on these particular when you combine technology with better access to specialist services, but with some other important particular issues here, particularly family support and family education to join in on this whole partnership in care. You also need a multi-sectorial strategy. In a lot of the work we're associated with, you need to be working with education, particularly with schools, along with working with health services. Interestingly, the other big factor that would make a really big difference would be increasing social connectedness between young people and between young people in the wider communities in which we live. So you can model how big that factor would be. Of course, what we don't necessarily know is how to necessarily do that in the areas in which we're working. So working with communities so that young people are not left out and the most marginal young people are not most excluded. And the most marginal young people can connect with care, with health, with education, but also with other social services remains important. And in many parts of our country, this is really challenging. Many young people feel more disconnected from the communities in which they live and more disconnected from the services that would actually help them. And we are facing cost of living pressures and financial pressures in Australia as to how to do that. So although we live in an age where technology could enhance connection, many young people feel they are more disconnected. So one of the biggest impacts we could have is that if we were able to connect people better with each other, with care services, and with families and wider social communities, we would see big improvements. All of those things remain pretty challenging. Most of our traditional healthcare providers don't really want to use technology, and they don't really want people using their own technology to connect with those systems. Most of our services don't work very well with families, and they don't work very well from the health sector across to the education sector or to the other social services sector. So what we tend to have is disconnected services and more young people disconnected from services and disconnected from their communities, hence creating increased risk. We've been involved in some further work at the moment about the trends in these areas. And unfortunately, in many of the areas in which we work, the trend in young people is towards more social disconnectedness, not more connectedness. And if that trend continues, then we're likely to see worsening mental health problems in young people. And if our service systems don't change to be more inclusive, to allow more young people to get in and more of those who are more marginalized to get in, then we're likely to see a deterioration. So the issue about being technology enabled, we see as being a critical aspect of future healthcare in this area. So a lot of the work we've been associated with is trying to develop new technology platforms and then trying to get services to use some of those platforms in the management of their care. This is not electronic or digital health records. This is not having health records in a hospital. This is real-time use of digital technologies to connect young people to care and then to have that care continued through self-management or through cooperative services over time. So the issue for us is, how do you take the personalized aspects of assessment I was showing you earlier and the aspects of measurement-based care and make it real? We think the only way that's ever going to happen in reality, as distinct from in theory, is through effective use of technologies. A very challenging idea. For us, classic electronic medical records in my own state of New South Wales is about to spend another $1 billion introducing a new system, an Epic-wide system, through all its hospitals, and says this will benefit a great deal of people. It'll benefit those who use hospitals a lot, and people of my age. Its impact on mental health and mental health for young people is likely to be very small. By contrast, we could be using the equivalent of A380s instead of horse and carts to connect people over much greater distances, much more effectively in the 21st century. It's a real challenge to do that in our services. And we find in a lot of surveying that we're doing, young people themselves are clear about how beneficial this could be. Many of their families are very clear about how beneficial this could be. Those who fund understand, and we've shown models of how effective it could be. The real challenge is, do providers of services, do clinicians really believe that using real-time data to deliver personalized care would be more effective than what they're currently doing? That remains an open question. I'll show you some data shortly about a lot of the clinicians we work with are not convinced at all that that would be the case. They think it will make their life more complicated rather than less complicated. However, we've been developing particular technology solutions. The one I'm personally associated with now is the Interwell platform, is one we've trialed extensively in healthcare systems. It produces dashboards, it allows personal tracking, it allows you to actually work with a person where they put in most of the data themselves to see where they're at in terms of their mental health, in terms of their distress, in terms of their functioning, and in terms of risk, for example, around suicidal behavior. And for those who are interested, we've written up large degrees of this particular work in appropriate journals. Bottom line of all that, it's very challenging. It's very challenging to get effective technologies, real-time technologies, ones that interact with real people, into our standard service systems. If we did, we've also modeled how we could much more effectively deliver care, how those who don't really need to use clinical services at this point could use self-care services and other psychosocial services, how those who really need to get to specialist care could go straight there instead of going through other steps of care that may actually delay where they need to go. And those who in that middle group, that indicated prevention, we could get those, or early intervention, we could get those into care more effectively. We could more effectively manage the demand that we have if we were smarter about the triage systems we used through technology. We've been interested in looking at the barriers and facilitators of this kind of implementation. It's interesting that at the individual level, young people, their families, very keen about it. Clinicians, very unsure. Services, critical to whether it happens, whether there's service leadership. In those areas where there's service leadership, we've been able to achieve implementation. With those, there's service reluctance or resistance, nothing happens. And when those services where there is actually agreement to do it, then there's an issue about engaging clinicians effectively as to how care can actually be improved by responding much, much more in real time to people's changing needs. In addition to that, we've been developing self-care programs. So prior to care or continuing care doesn't always remain dependent on clinicians. And through the appropriate kind of mental fitness programs, through an emphasis on the extent to which people also can assist in their own daily management through activities, through sleep-wake cycles, substance use, physical activity, and importantly, social connectedness, we could improve outcomes by continuing and engaging people in their own care much more effectively than we've done in the past. And that's an issue which can be done very simply through the right kind of smart digital systems, but those smart digital systems being promoted and supported by the healthcare providers that we work with. Important in all of this is the role of public education and engagement. These are just two of the things I'm involved with. These two books, Minding Your Mind, we knew books I'm associated with, but the podcast they're associated with is extremely popular. And say lots of young people and lots of service providers want to know more. And we need to be more proactive in the way that we provide information and engage with the issues that they do. And the podcast I'm associated with is particularly emphasis and driven by support for young people, what we need to happen. So what I'd like to say at the moment is we need to have this strong focus on early intervention and what we do for young people. It remains the case we have to be very cognizant. Are we attracting the right young people to care? In our own society at the moment, due to cost barriers, due to availability barriers, we're demonstrating we're quite effective at attracting those who are more educated, those who have more resources, those who are more likely to have care, get more of that care, but we still struggle to get more of those who are more disconnected, more disaffected, more young men, more of those in trouble into care earlier, as distinct from having those young people come in through emergency departments and through acute care. By using clinical staging models, we have been able to persuade our governments and others that we need to have designated services like Headspace services, like other services, which say the earlier we connect, the more effective we will be at preventing progression to more severe outcomes. However, when we do that, we've had to emphasize the assessment and the interventions need to be multidimensional. It's not just a matter of doing one thing. And amongst all the factors that we most emphasize, it's that of function. We need to make sure that we support young people to be in education, employment, and training, to stay in it if they're in it when they present, or if they've gone out of it, to get back into it in order to get well. And it's simply systems that just provide more front doors, but don't provide effective care, at the end of the day, are not cost efficient and not effective. So we have spent 25 years in Australia largely increasing access. Now we're saying access alone is not enough. Access has to lead to better care and the right mix of primary care and specialist services. And then within that context, we are trying to arrange that better by testing new health service models that integrate technology into that care, but provide better access to specialized assessment earlier in the course of illness, not waiting till people are simply at later stages to provide more effective care. To achieve any of this, we think it is essential for services to bite the bullet about new technologies, new personalized technologies, not digital medical records, not simply records-based systems in large healthcare systems, but those that actually genuinely interact and allow the empowerment of young people and their families to be genuine partners in care to achieve more effective care. An interesting factor that I haven't gone into much today, but could go into at length at another time, is the development of new AI models. We are working on new models that will become more responsive over time, that will allow a young person and services and service providers to make greater use of generative AI to feed back where a young person may be and what happens next. It's a really interesting area because we think it'll be the next big phase in development of more effective models that can be scaled. Lots of challenges in that area, lots of potentials of risks, but we would suggest lots of actual potential for answering a lot of more personalized questions very quickly. Interesting with the technology, given the barriers, the resistance we have amongst the traditional professions and a lot of providers, is the reality it's going to happen. I have another article in the Medical Journal of Australia 5 years ago about the Uberization of mental health care. Whether you like it or not, it's happening. Whether you like it or not, there will be private markets that attempt to meet these large sets of needs. What I'd suggest we need to be doing is working with those models to try and make them better rather than saying it won't happen. And then what is really challenging is the coordination of those cares in each of the communities in which we live. Just like in Canada, it's not a matter of how many provinces you have, it's a matter of how many effective communities or regions you have. In Australia, we have over 50 functional regions, and trying to make all these models of care work in those functional regions is a matter of local cooperation and local working with communities, young people, health providers, and others to make sure this happens. So from my point of view, that's then the next level of health system organisation that's required. And that's partnerships in healthcare, primary care, specialist care, substance misuse, emergency care, but also partnerships with education and training and social services. And perhaps the biggest factor that we have not yet come to terms with is how do we grow the degree of social connection so that young people feel part of those communities over time and not increasingly disconnected, which appears to be the current trend. So I'll stop there, Andy, and happy to take any questions or comments.
Perfect. Thank you so much, for this presentation. If anyone has any specific questions, you can type in feed loop, and I will, direct the questions to Professor Ian Hickey. But I can start off with some of my own questions that I've sort of gathered. I think actually through the conclusion, I know you know that my interest is in machine learning, AI, and these new technologies. So the first thing that comes to mind is sort of something that you said you could make a whole nother presentation on, which I completely agree, maybe multiple. But I sort of wonder how these new technologies like large language models, generative AI, these sort of buzzword things, how these sort of technologies differ from more traditional machine learning, classification or regression tasks, how you see generative AI fitting within that space when tackling things like, this model of right care, first time for youth in Australia. Because I feel like this new, bubble of really innovative ideas using things like generative AI is very novel and new. And with that comes a lot of different challenges, but maybe also can tackle tasks that are very specialized. So maybe you can,
Yeah,
address that.
let me give
No,
let
that'd
me
be
give
very
a few
helpful.
examples. One, yeah, give you one is not to throw out the old technologies. Some of the machine learning techniques that we have are extremely useful, and some of the data science in that area is extremely useful. In fact, we have a publication out this week about using some of the newer data analytic techniques to look at individual trajectories of suicidal behavior. So if you look for one of our just online right now, you see coming out is we now can see if you get a small amount of data from certain individuals over time. So if you start to use digital technologies, we've been doing in Headspace services, and start to look at one construct like suicidality, at a group level, we're very poor at predicting what happens to particular people in terms of their suicidality. What you find with these other models, though, you can develop much more individual trajectories of what is happening. You can deal with much greater amount of data. If you get from the same individual just a few data points over time, you can start to make much stronger predictions around the nature of their suicidal behavior or the nature of the course of their illness, just through being able to deal with data much more effectively at the individual level and not retreat to group averages, not simple regression models, but much smarter learning models. Now we're trying to take that another step, Andy. And so we have a bot development right at the moment about using interaction where you can simply put in open free text, open questions. And what the models start to do is rather than following simple regression models or simple machine learning, they don't just look for an optimal path, they can change paths. So in relation to key bits of information, more like clinicians, they can jump across paths to alternative explanations much quicker than simple or prior machine learning type models. So I think we're on the threshold of really smart. Now, these are really smart clinician informed models. Like all AI type factors, it depends what goes into those models that makes a huge difference. So we're trying to use the combination of available material from the evidence-based literature plus smart clinician training models into what can happen. So what that would allow is a lot of services that don't have access to more specialized assessment, really, and a lot of young people who do not have access to that kind of assessment, could essentially get the equivalent of meeting highly specialized specialist providers very quickly in an assessment process, and to
Mhm.
potentially change pathways of care very rapidly, which is of course not possible in our current world. So it's the learning capacity of those systems. If you've got the prior learning that's going on, combination of clinician information plus the evidence bases that are out there, but then the collection of information from individuals. So what they really emphasize, Andy, is how important it becomes for individuals to be putting their own information into those models very quickly so that key decisions can be made. So
Mhm.
you're going to need not just the models themselves, but smart ways of collecting data from individuals to feed that very back quickly into those models. So the models won't exist in isolation from clinical care, but they'll make much smarter use of information that's being collected in those clinical systems very quickly to make much better predictions about what next when things are going wrong.
That sounds wonderful. That sounds like a, a really good use of, all the different technologies that, AI and machine learning has to offer. Um, Okay, so thank you for that answer. We have another answer or question in chat from Otto Lim. This individual says, "Brilliant presentation from Vancouver, BC. We still have issues about young people being able to keep their cell phones while in hospital care. Often, this is their safety object in connection to their supports. They are then isolated. Assumption Assuming that young people or adults will misuse their phone inpatient, this does not happen in acute medical units, etc. For example, stigma. I'm not sure if there's a question in that, but maybe you can sort of address, this comment.
Yeah, it's fascinating, isn't it? The rules and regulations that we have about taking things away from people in acute units. I mean, it is an interesting question. What exactly is the misuse that staff assume will happen as distinct from what will be the loss, and the loss of connection with others, the loss of being connected through phones, through the world, is an interesting one. So I think it is like many of the rules and regulations that we have in our control settings. It's as Otto's quite right to highlight why, in what settings, why is that rule in place? Is it appropriate? Is there really a risk of significant misuse? Or, in fact, are you making the person's isolation worse by not allowing them to connect freely with those they need to connect with? So I think we could all possibly think of reasons and situations why you might want to, in some instances, limit use. But it does seem to me one of those arbitrary rules that gets made in our institutions, when really for younger people, we should be thinking the opposite. How do we maximize them staying in connection with their social world, even when they're in hospital?
Okay, perfect. I'm not sure. Actually, this is a perfect time to wrap up. It is 10:30 PST right now. So thank you so much for, taking the time out of your day, Professor Hickey, for giving us this presentation. And thanks everyone for joining this conference. And I believe next we have a keynote presentation from uh, Roberto Sassi, as well as Maximilian Meyer. So thank you so much, everyone.
Thank you.
Yeah.